Just so you know, I've started recording. So should we begin at 1 minute past? Just give some more people a chance to come in.
Right. Good evening, everyone. I'm Florence, and I'm T3 from King's College Hospital, and I'm also a pre-specialty committee member of the Young Diabetologists and Endocrinologists Forum. Thank you for joining the diabetes session of the National Endocrinology and Diabetes Taster webinar series brought to you by the Society of Endocrinology. We are meant to have Professor Patakar today, but unfortunately, he could not join us due to an emergency. However, we have two other fabulous speakers, Dr. Antonia Brooke and Dr. Thomas Crabtree, who are very eager to share their knowledge and insights in diabetes with us. Before we start, I would like to remind the audience to turn off your mic and video during the session, submit your questions in the chat box, and we'll go through them in the end. This session will be recorded and uploaded onto the Society's member page and YouTube as well. We will send a feedback survey to everyone within the next few days, and we'll send you the certificates of attendance once you have completed the survey. Our first speaker today is Dr. Antonia Brooke. She is an endocrinologist at Royal Devon University Healthcare NHS Foundation Trust. Her additional roles include being lead for peer review, council and clinical committee member of the Society for Endocrinology, a trustee for the Pituitary Foundation, and chair of the Specialist Advisory Committee for Endocrinology and Diabetes for the Royal College of Physicians. In this session, Dr. Brooke will discuss the changes to the curriculum and will share her top tips for applying to endocrinology and diabetes. Without further ado, let's welcome Dr. Antonia Brooke. Let's share your screen.
I did the elemental error of sharing my screen without unmuting myself and then not being able to find myself. Florence, thank you. Can you hear me? I'm currently in Spain, so it would be good just to get that confirmation. And hopefully all is on hand to let me know if I suddenly cut out. So thank you. That's really, really nice introduction. This is the task I have been given, what you need to know about the curriculum and top tips for the application. I have to say that really the nuts and bolts of this are fully and freely available on the JRCPTB website. So hopefully I'm not going to spend too much time telling you things that you can look up with a flick of a button, but hopefully a little bit more time on inspiring you into why you might want to apply and what we're trying to achieve as an SAC in terms of the finished product. And how you can help yourself get an NTN and more importantly, gain the skills to be our leaders of the future. So in some ways, I wanted to start with the end in terms of what you become. This is my department. If I can get, oh, it's not working. Oh, there we go. Is that moved on? I hope. So this is my department.
Yes.
Great. I thought I'd give you some insight into the sort of portfolio of careers that it's possible to have within diabetes and endocrinology. So here on the top left of the side is BJ Vaidya. He's a professor of endocrinology. He does diabetes in pregnancy as well, general medicine. He's on the board of the British Thyroid Foundation. He's had active roles in the society and he delivers radioiodine to our patients. Next to him in the glasses is Professor Angus Jones, who is one of the leading diabetes researchers of his generation. He's paid for by the university. but he does some clinical sessions with us. And then in the middle's me. You've heard about my additional roles. I don't do any diabetes. I just do endocrinology and general medicine, and have these various other roles to keep me busy. Tom Fox in the funny hat is he does diabetes, community diabetes and acute medicine, and doesn't do any endocrinology, but he's also the sort of second in command for the medical school and very responsible for medical students in Exeter. Next along is Julia. She's currently on maternity leave, Julia Prague. She does as well a bit of everything. So she is part funded for research. She does diabetes, endocrinology, she does general medicine, and a bit of everything. And then straight below her is Kash Patel. He's a professor of diabetes. He's really interested in genetics of diabetes, and he also does some clinical sessions, but paid for by the university. Roderick is our current clinical lead, and he glues the department together. He does diabetes, endocrinology, general medicine, and he's an expert, I would say, in all of them, and likes to do amateur dramatics, hence the slightly dodgy photo. Helen Lockett is just doing diabetes and general medicine, and she is our deputy medical director. Next along is Neil Walker, who is an international baseball player and also a transplant diabetes surgeon, medic, and the training program director for F2. He actually isn't an international baseball player, but he didn't send me a photo, and this is the one of Neil Walker that I was able to find on the screen. And here's Kagabo Hiwa, who is our newest recruit, who's obviously the only one that does any work by the looks of things, representing a poster at the Society for Endocrinology. So he does diabetes, endocrinology and general medicine, and he's an international medical graduate, and we're really glad to have him on our team. Actually, this is the real Neil Walker, who finally got to me today with a photo of himself. On the left-hand side of the screen here is Neil Walker. For those of you that are eagle-eyed, you may notice in the way that I never do, that on the right-hand side of the screen is actually David Walker, his twin brother, who is a gastroenterologist in Bath, but easily confused. So that's just giving you an idea of the sort of portfolio career that you can have within diabetes. It's really easy to combine it with national roles, with highly specialist roles, with community roles, with roles in management, in research and teaching. And actually, the opportunities are really there for you going forward. And as you approach the end of your training, there will be choice about what career you want to follow. So I don't think you need to worry about that. So perhaps we just spend a little bit of time about, well, that's now, but what will the future look like for you? And I think we need to think about this in the context of actually how healthcare is changing. So this is the context of how the new curriculum has been developed. So we know there's an aging population. There's many, many more people living with chronic disease. And that means there are more acute admissions of people when they become well. There's lots of sort of national drivers about what care should look like. So the NHS 10-year plan, the National Outpatient Transformation Programme, and all of this really is about driving care out of hospital. So population-based medicine and changing delivery of care so that we're reaching out a little more. We're not seeing everyone in clinic. We're trying to avoid people coming into the service so that we're doing more in the patient's homes and supporting primary care more. There's a real push towards sustainable healthcare. And as I say, the population-based medicine involves actually doing things like limiting inequalities, trying to prevent disease from happening and things like that. And that's particularly relevant for our specialty in type 2 diabetes and obesity, where really there's a lot to be done there in terms of improving the health at a population level. There's loads of guidelines and things to help us with that. So there's things like Getting It Right First Time, which is a sort of national data-based program to try and get care in the appropriate place. And some of that means super specialised centres for specialist care and then networks of care. And that's how we need to deliver care. And that means that the role of the MDT, so the multidisciplinary team meeting, becomes more important. That's firstly just in terms of discussing complex levels at a super specialist level, but actually also it is about consultant-led rather than consultant-delivered care. And I think for the future, we need to be those leaders that can help develop pathways and protocols, support our nursing colleagues, physicians' assistants, trainees, the people that actually are doing a lot of the delivery of care, because this won't all be delivered by consultants in the future. And then I really want to emphasize the role of the patient and artificial intelligence. I think, like it or lump it, there will be that coming along. It is actually, I'm sure you've discovered already, actually unusual to see people now, certainly in clinics, that haven't done a bit of their own research beforehand or Googled the words that they're supposed to be looking at. And whilst people say they're only looking at official sites, they often need some navigation about how to do that. But also, we need to think about how we can really work in partnership with our patients and give patients and their relatives more power. And there's quite a lot of work going on in that. Some of you may have heard of Martha's Rule, which is about seeking second opinions if you don't believe your first opinion when someone's really unwell, or PIFU, which is patient-initiated follow-up, or actually changing the way that governance is managed so that there is more action in advance of something going wrong rather than when something goes wrong. And the reason I stress all this is because I think it's really important when you're thinking about how to develop your careers that you consider about what it should look like. We cannot and should not have that paternalistic approach to our patients that was perhaps a thing of the past, where the consultants stood at the end of the bed with 17 different doctors standing round and talked at the patient. And I think, that is really well demonstrated actually in this slide. I'm not going to go through the details of this, but it's just to say that actually the delivery of care will change, and patients need to be absolutely at the centre of this. And when you're applying, when you're thinking about what projects to do, I'd say this is an area that really needs a lot of thought and consideration, and something you can really add to, because us old fogies is not the way we were trained, and so it's really something that you can be putting things for the patient forward first. Advocating for your patients, making sure that they've got a service that actually meets their needs, and I think that's really important. And so it's firmly with that in mind that I think it's really important that you work with patient charities. So if you haven't looked at any of these websites, I think they give you really valuable information. And actually, if you read all of the patient information sheets, that will give you really key and valuable advice about how to use language that actually is something that your patients can understand. And that's something that I think when you've been through a medical training can be really hard, new language to learn about how to get the information across whilst not over medicalizing it. And I think the charities, there's a lot of work that can be done. If you go to any conferences and there's charities there, if you've been to Diabetes UK, go visit the stands, go ask them what they're up to, because actually some of the work they're doing is extremely valuable and really needed, particularly in a time of funding crisis within the NHS. I think we also need to consider the fact that actually social media is obviously very important in people's lives and pretty unregulated, as you know, at the moment. And that means they may know about you, they may know and share things about you, and they may have looked things up about their condition or around care, which may or may not be wrong. And I think that part of the role is then actually stepping in and trying to guide patients to sites that you know are going to give reliable and regularly governed information that can really help them around managing their own condition. And with that in mind, on the very right of the screen here is Epic. Some of you work with Epic. So that on there has a patient portal, which allows patients to directly get in touch with you if they've got questions and things like that. And I think this is a really valuable part of our future. And if you give certain patients the power to be able to manage their own condition, type 1 diabetes is a really good example of this, where you would hope that a good proportion of patients will become much more expert in their conditions than you will ever be. And actually, you need to change that relationship with your patients to respect that and work out what they need from you to make their path easier, because that's the big complaint that they'll have. So bearing that in mind, what does the new curriculum have in it? Well, it's changed to of the population. And so it's firmly launched into the ideas of an ageing population, so giving more generalists that can manage an acute medical take and cope with complex comorbidities. So you're not having to ask people all the time to come and give an opinion on something. And actually, I think we will be a very major part of that in terms of making sure that our colleagues have some basic understanding and knowledge of diabetes, so that they can manage those inpatients with diabetes without our having to wade in and our help. We have to consider the population health and inequalities. Not all patients will be able to manage or will be prioritising their health, but if we can get those that are to be self-managing, that gives us more time to cope with the people and work out how to get to the people that really need that extra help. So what you're really thinking about there is not only the person in front of you, but the 10 people who aren't in front of you that could really do with your help. The overall length of training is the same, but specialist training now is 4 years, not 5. And I'll come to this in a bit, because actually a lot of time people say, well, what happens if I don't get a number originally, or what happens if this, that and the other? And actually there is not a rush to complete your training. It is much better to use your time wisely and actually get the skills that you need, so that when you are a consultant, or even when you're an ST4, that you hit the ground running. So we are part of a group of Group 1 trainees, so we are dual training. This again, as I say, means that we can't single accredit, so we do general medicine and we do our specialty. And there are some new recruits into Group 1 training and bumped up training for other specialties that previously could drop the general medicine. And this has huge advantages to us specialty, because it means that going forward the medical reg rota will be better staffed, and that also includes probably some of you now in terms of the IMT3s on the rota, but also we have other people that can come and help us with ward cover. These people typically don't have their own general medical wards, so they can come and help, and that would allow you to go off and do some either general medical clinics or more specialty clinics, and that makes it more attractive to follow medicine as a career choice, and we're seeing that within our recruitment numbers, which is really positive. So here are our teammates. We are Group 1 specialties, and those in italics there, so neurology, palliative care, rheumatology, they're all new recruits to Group 1 specialties joining the general medical rota. A lot of this is still being worked out, and it absolutely is not equitable at the moment, but everyone is really aware of that, and there is a lot of work being done about having to try and make it more equitable. So it's a good time to join diabetes and endocrine. I think that things will definitely get better, particularly with respect to general medicine. What do we do in the curriculum? Well, it's all about capabilities in practice. So this is a competency-based curriculum. So we try to move away from particular numbers into, are you competent to manage this? And the dual curriculum split into generic, internal medicine and specialty SIPs. I'm not going to go into them. They're all freely available on the JRCPT website. There's no particular surprises there, but actually it's a really exciting time to be part of our specialty. There's things like closed loop, so artificial pancreas is coming along, and genetics in medicine, new treatments for oncology and endocrine practice, loads of stuff. And I think typically the phenotype of an endocrinologist is seen as someone who is very reasonable, very good general physicians, good at taking on extra roles. And actually that means that it's a really collaborative, supportive environment that you will find yourself in a consultant job with, and you cannot underestimate how important that is. But I imagine a lot of you know what's good about our specialty. So I guess I just need to benchmark a little bit that concerns everyone. General medicine, being a general medical registrar, is always number one on the list. So the thing to say about that is we have a role in trying to make this better. I think it is getting better. It's really hard because running a medical tape now, there are so many people coming and going, and often you don't know about them. But actually remembering that part of your role as a medical registrar is to really support and encourage your team, build them up for the future. I've mentioned the fact that there's new people on the rota, which makes it good. And actually, I think we forget sometimes the good bits of general medicine. So you're in charge of the hospital, that your opinion is really listened to, and you do see some really interesting and challenging cases and save lives. It's a great leadership opportunity. And actually, if you still don't believe me and still find it immensely stressful. It is only for 4 years. When you do general medicine as a consultant, it's a very different thing altogether, and it really can be good fun. So it's worth sticking at it, even if it's the bit of your job that you find less rewarding. But I challenge that actually, I think that's already and is going to continue to change. And actually, as general physicians, but also as diabetes and endocrinologists, I think we're really good at it. So I think you shouldn't be scared of it. I think that it's a great thing to try and make better, and that's something very much the SSE is aware of. In terms of dedicated specialty time, that's something that people are worried about sometimes. Will I get to my specialist clinics? It's absolutely a problem. And part of that is in the rough guide, which is available on the JRCPT website. It gives some indicative numbers of what we would hope that you would be able to achieve. And we think that you would need around this to be qualified at the end of training. But it's absolutely not a tick box, and therefore this isn't that if you've only seen 4 patients in clinic or not 8 patients in clinic or whatever, that you're not going to get through. It's about equivalence of experience and actually trying to take this training yourself in hand. And you can gain equivalent training through doing things that are much more or very relevant for the future, including things like MDT, presenting at those or chairing those or doing advice and guidance. There's lots of opportunities. We're really aware that there's regional differences in training, but also in service. And that is something that we continue to work on. But actually, as we form more networks and share resources, I think, again, that becomes less of an overriding problem. So there are things that we are working on. And this is, again, just really to reassure people thinking about this. About what we're trying to do to get that balance between specialty time and general medicine as good as it can be. We are never going to step off the acute and general medical rota in full because it's an important part of our job. A lot of people really enjoy it, but actually getting the balance right between service and training is really important. And this is just saying some of the things that we can offer that actually may be really attractive to trusts. And then at the bottom here, I've just put around strong IMT3s. So actually, if you are delayed in getting a number, or you're doing something else first, or you've got a bit of time in your IMT roles, there is a lot you can do to really get yourself going at being able to manage a clinic and things like that, so that when you do start your number, you hit the ground running. So I was asked to cover the interview. This is how you get through. Again, this is available on the JRCPT website. There is no particular smoke and mirrors about getting through. It's a very straightforward thing. The people interviewing you will be either experienced clinicians, most of whom will have done interviews before, or senior trainees, which can sometimes give you an eye from someone that has only recently been through the situation. It's basically 2 stations, and in each station it's divided into 2. Each half is 10 minutes. And then in the second station, you get a mark as well for communication. That's not a separate question. It's just an overall score that comes with that. So the clinical scenarios, they're not particularly complicated. We want to know how you approach a patient. And as much of this is around using logic, using your differential, just demonstrating how you can communicate with patients, how you are showing understanding of what the patient may be going to and getting down on their level, and then managing uncertainty that the patient might be feeling. And, it's as much around that than it is around anything else. It absolutely is something that we try to take into consideration if you, in an IMT3 job, have not done diabetes and endocrine, because it's positively encouraged that you get that experience outside. And actually, one of the things I would say is if you can hit the ground running at being able to manage a medical take and it not being something that you're really struggling with, that will pay absolute dividends in terms of your quality of specialist experience. And that's probably the single thing that is most likely to trip you up in the interview, is if we're not convinced that you can manage a general medical take. The scoring framework, again, I think this is all available on the JRCPT website, and we do use the full range of scores. So there are people that get full marks in interviews, and there are people that get ones in interviews. If you get ones, I'm afraid that's game over. If you get 2s, you can have 2 2s. And likewise, if you get 3s and a 2 or things like that, you enter a pot of people that at the end of the interview process, we sit down and discuss, and we look at any variance in scores to try and make this as level a playing field as possible. It is worth saying at the moment we are getting positive numbers for our recruitment, which is really fantastic. So even if you do get 3s or enough 3s to get through or above, you are then ranked with a weighted score according to your application, and therefore you still may not be offered the training post of your choice, even if you have got through. But I just want to end with just talking about, again, what a privilege it is to be an endocrinologist. And I know that sounds saccharine, but it's actually true, and I believe it. And I think you're entering this stage at exactly the right time. But all of this is not around ticking boxes. It's not around trying to go to 15 pituitary clinics or whatever it may be. It's around being a good clinician. And I just want to leave you with this final quote from an article in JCM a few years ago now about what we are actually trying to deliver. So the process of delivery of clinical care with clinical excellence is nuanced and requires cognitive and personal skills, which are not as widely discussed or as easily measured as achieving quantitatively targets or following guidelines. And that's what we want from you. And that's what we're going to try and get out of you at interview. We want to know that you're going to be our excellent colleagues of the future that are going to lead the specialty to the next level. Thanks.
Right. Thank you, Dr. Brooke, such an excellent talk and for sharing valuable information about applying to endocrinologists and diabetes. This will greatly benefit all participants who will be applying to the specialty in the next few months. We will now move on to our final speaker today, Dr. Tom Crabtree. He is a consultant diabetologist recently appointed at the University Hospitals of Derby and Burton NHS Trust, having completed SPR training in the East Midlands. Dr. Crabtree is a former chair of the YDEF. He has completed a PhD, including a range of research projects and working with ABCD on its national-wide audit programs with responsibility for the DIY APS, closed loop, and omnipod audits. In this session, Dr. Crabtree will talk about the latest advancements in diabetes closed-loop technology and how they are transforming patient care. Let's welcome Dr. Crabtree.
Thank you for the excellent introduction, and thank you everyone for joining. And I agree with everything Dr. Brooke has said, and I agree it sounds saccharine, but I do think our specialty is absolutely the best place to be. I think we're in an absolute golden era now from both a diabetes and endocrinology perspective, and I think it's a really exciting time. So I'm going to talk a little bit about my journey through training and a little bit about why I chose diabetes and endocrinology, and then there's going to be a bit more of a focus on some of the newer things that are happening in diabetes, because actually when you look at diabetes even 20 years ago, the treatment options were metformin, glycoside and insulin, and the world has come on drastically since then, either from a technology point of view or from a pharmacological therapeutics point of view. And it really is an exciting time to be in the diabetes side of the specialty. I guess that's my other disclosure, because I think most of your other speakers have been endocrinologists, but I am very much a diabetologist since starting as a consultant. These are my disclosures. So I started medical school in 2008 in Nottingham and just never got the courage to leave the East Midlands, which isn't necessarily a bad thing because I'm in love with this part of the country. Graduated in 2013 and did my foundation training in the region. Always enjoyed the topics of sort of diabetes and endocrinology at medical school, and then through kind of happenstance, I had 2 diabetes and endocrine jobs in my foundation training, which on paper shouldn't have happened, and only happened because a ward in my F2 year had changed specialty at short notice, and they kept the junior staffing the same. So I ended up having sort of 6 months of diabetes and endocrine experience there, then doing my core medical training, as it was back then, doing another diabetes and endocrinology job with one of the teams that I'd already worked with in Lincoln, who really did support me and push me to apply for it. I then started training in 2017, quite early on in that, becoming a member of YDF and through YDF, which is a great organisation. Would recommend you all looking into this in more detail. Had lots of additional roles, whether that's being seconded to the Specialty Advisory Committee, working with ABCD and various other organisations, and eventually chaired YDF a couple of years ago, which was a great experience and sort of a national level to work with lots of different organisations and really try to change what YDF was doing or some of the ways that we were working. About halfway through my trainings after ST4 back in the day, so that was 2 years in, I took time out of programme to do my PhD again at the University of Nottingham with Emma Wilmot in Derby and Idris, doing lots of stuff around observational data, real world studies, diabetes and frailty, but a lot of stuff related to diabetes technology, which has had quite significant national impact in terms of policy and developments and nice guidelines. And there are plenty of opportunities to take the long and winding road through training once you have a number, or even before training if you're looking for things to do to potentially improve your application. There's plenty of senior clinical fellow posts, there's plenty of PhD opportunities out there for anyone who's interested in pursuing them. My time doing that was slightly muddied and extended and a bit messy because of the COVID-19 pandemic. But I graduated from my PhD this year and finished training, and have within the last month started a substantive consultant post in Derby, doing mostly doing all the diabetes and the stuff I enjoy. So I do community diabetes, young adults, transition, pump clinics, and foot clinic, and then some inpatient stuff and general medicine as well. So all things that I really enjoy doing, and not doing so much endocrinology these days. So diabetes and endocrinology, well, for me, some of it was the exposure that I'd had to the specialty. And if you're someone who has had less exposure, then I would encourage you to try to get to some clinics and really see what we do on an outpatient basis, because what we do isn't inpatient, isn't necessarily what our jobs look like, nor what your job would look like when you hopefully get a training number, finish training and become a consultant in the specialty. It's incredibly intellectually stimulating. Endocrinology is incredibly logical. Sometimes you can look at blood results and come up with answers that no one else has thought of, or have a completely different take. And that can be very rewarding, very, very stimulating. And diabetes increasingly is that way as well when it comes to interpreting the data we get from things like pumps and CGM, which we'll look at in a little bit. One of my favourite things about the specialty is the lifelong relationships you get to develop with the people that you're seeing in clinic. And some specialists have, in other specialties, may see a person for a short period of time. You know, after their heart attack, they may fix that, see them a few times and discharge them, or fix the immediate problem. But often in diabetes and endocrinology, cure isn't possible, and we're working on lifelong management of chronic medical conditions, which means that you can see someone when they're 18, see them through pregnancy, see them after pregnancy, and then see them again towards the end of life. And we see people a broader spectrum of age ranges than most medical specialty, which is really great. And the relationships and rapport that you build with patients is really valuable, and one of my favourite things about the specialty. The other thing is we're very MDT specialty, so not just thinking about sort of the diabetes nurse specialist, endocrine nurse specialist, dietitians that we work with, but we tend to have our fingers in lots of different pies in terms of our cross-specialty relationships. So that might be that we're working with vascular or orthopedics in foot clinic. I've got a quite very strong relationship with the gastro team at my local trust for the patients that we share that have gastroparesis or type 3C diabetes from their chronic pancreatitis. That might be on the endocrine side, working with your ENT surgeons in the thyroid service, or might be working with your genetics team. There's so many different specialties that we're working closely with, and that network can be really quite stimulating as well. I think we're probably one of the most rapidly evolving specialties, as I've mentioned already, and the treatment options are changing on a monthly basis, it feels like, with new drugs coming out all the time, new scanning modalities, new tests that we can do, and so that really is exciting. The other advantage if you're anything like myself, is that there are no procedures, particularly in diabetes and endocrinology, unless you're desperately inclined to do additional work to do your own thyroid biopsies and things. But most people don't do that, and the fact that we don't do procedures to me is a benefit, because our craft as a specialty is our communication skills, the relationships we build, and the relationships we build with patients, and our ability to work within NDT settings. And finally, general medicine. And sometimes through training, general medicine can feel difficult. And I think I have worked both before and after the new curriculum as a registrar, and there was already a notable reduction in the amount of general medicine it felt like we were having to do as high specialty trainees. We didn't have any protected time away from general medicine in the deanery that I was trained in the East Midlands, but it did feel like we were doing less than we were when I first started training. And actually, general medicine, it's really fun. Your opinion is valued. It is very rewarding, and doing it as a consultant is very different to doing it as a registrar. But I do think we do make for some of the strongest generalists in the hospital as a whole body and not single organ specialty. And as Dr. Brooke has already highlighted, the opportunities for how you develop yourself are vast. So you could be someone who becomes a clinical leader and a national leader, so working with NHS England, something like PARFA. You could be more inclined to become a clinical academic. There's lots of active research in both diabetes and endocrinology that gives you the opportunity to do that. You could be someone who just wants to be an excellent clinician, and that is absolutely valuable and needed within the team. Lots of what we do, whether that's with patients, more junior doctors, or with medical students, is around education. And lots of what we do around patient care is about coaching and supporting people, I feel, these days, more than doing that more paternalistic approach. There's lots of opportunities for service development, and we're having to really rethink about the way we deliver some of our services. And you also have the opportunity, certainly within diabetes, to consider whether you want to work in hospital or whether you want to take a more community-based role, and that is something that is more interesting. And lots of people do both diabetes and endocrinology. Some people do just diabetes. Some people do just endocrinology. Endocrinology, and you've got the option there to sort of build a job around what interests you. And so I think you can really tailor the specialty to what you enjoy the most, and any additional roles that you might want to take on. So this comes to the rapidly evolving bit, and this is an article that I wrote with PARFA for BMJ Innovations about the rollout of Freestyle Libre continuous glucose monitoring. And when I started training in 2017, which is quite nice that this timeline starts there, in Derby we had reasonably high uptake of Freestyle Libre because we had quite a forward-thinking CCG back in the day. But it was still fairly early days. We couldn't give it to everybody. But in that time period, because of lots of the work that's gone in terms of ring-fence funding, guideline changes, we now have 90+% of our people with type 1 diabetes using some form of CGM, to the point that when I see someone with type 1 diabetes in clinic and they present me with a blood glucose diary with 4 readings a day, I can find that really quite difficult to interpret or know how to change their insulin doses or what advice to give, because I feel like I'm not getting the full picture. So things really have changed, and this is a key skill that we would be expecting registrars to develop in terms of interpreting the data. Things are changing less quickly when it comes to type 2 diabetes in the CGM space. We do have more people on type 2 than we ever had using continuous glucose monitoring, and Freestyle Libre is one example. But that there is a bit more regional variation in that, and for instance locally we don't have particularly very high uptake amongst type 2 individuals. So for those of you that aren't aware, CGM is a sensor. There's various different types of it. Freestyle Libre, probably the most common one you encounter, that worn on the skin. They have a filament that measures interstitial glucose levels, so you're not getting the blood glucose, you're getting the blood glucose measured from the subcutaneous tissue. And this does mean that there is a slight lag. So sometimes if people are dropping very fast, their Libre sensor might say that their glucose is in normal range, but they may in fact have hypoglycemia. but it's really useful information for them to have nonetheless. And the data that we get is overwhelming compared to what we used to get. And so, for instance, you may have this individual whose HbA1c, if that's what you were judging it off, looked very good in clinic, close to target, or even less than 48, which would be ideally what we're aiming for. But really, what you can pick up is problems with hypoglycemia more. You can pick up peaks after meals, and you can really start to dig into, where can we help support the diabetes management? What does need to change, and what advice can we be giving? And it is, like I say, a little bit overwhelming when you first get used to it. And the general advice we give, if you ever see any of these downloads when you're attending diabetes clinic, is we use this, what we call an ambulatory glucose profile, which is your sort of 2-week average, to come up with general patterns of what might be happening. So we can see here, perhaps they're rising overnight and into the morning. And then we can look day by day over the last 2 weeks. We can also get it on a much bigger scale than this, so we don't have to necessarily look at it in this format. But that might mean that we're having conversations then about, are we increasing the background insulin, or actually is this because they're having hypos before bed then overcorrecting? And that can really inform conversations that we're having in clinic and help us move management forwards. The new thing that's happened is hybrid closed loop therapy. So we've had insulin pumps for some time now, which are a different way of managing diabetes to multiple daily injections with carbohydrate counting. The main difference being that the pump used to be able to give a pre-specified infusion of insulin over a 24-hour period, which meant that if someone needed a bit more background in the morning and a bit less in the evening, for instance, we could vary it over the day and give a little bit more nuanced control than a once daily background injection. Because of the development of continuous glucose monitoring, we now have systems where the two connect together. And lots of this was actually patient-driven innovation, where patients had at one point hacked their own pumps and created their own smartphone apps to connect the two together and do what the new commercial systems offer. And essentially what will happen is the pump will see your glucose level go up on your glucose monitor. It will give you more insulin. If it sees your glucose levels are steady, it will maintain its insulin delivery as it is. And if it sees that you're dropping, it can suspend automatically to try and prevent that hypoglycemia. So people do get a lot more time in target from using these systems than anything else. But do still need interacting with, so it's not completely artificial. People still need to put in their carbohydrate intake, for instance, but it's a little bit more forgiving around the accuracy of that, perhaps. And people need to be very switched on about seeing if the pump has failed. It's not the easy option. If you're someone with very high glucose readings who isn't interacting with the glucose data from your sensor or doing finger pricks, if that's what you were doing beforehand, then it does make us worry that you might not recognise that the pump has failed because you've only got short-acting insulin in your system. You may get quite quickly proceed towards DKA. So that's obviously a concern. And then some people do worry about the stigma or problems with wearing the devices. If people see them, what might they think? There are issues perhaps there for around body image, or because it's adhesive, some people have skin site reactions, but we are learning more and more as we roll these out, how best to manage those situations as they occur. And this is the sort of data that we get from one of these systems as an example. And you can see this particular system, this is a download from a Medtronic pump, but you can see in comparison to 3 months ago, you get all of the different data points around what's happening with their pump. And that can be a starting point for whether we're making changes to settings or whether we're talking to patients about some of the things that they're doing in terms of interacting with their pump or their diabetes to try and optimize things further. Now, 70% time in range is what we aim for. So this is an individual with diabetes who's doing incredibly well. So there may not be an awful lot to change, but then they may, be concerned about rising in the evening, and there might be things we can do to support making changes to help with that. And then we can dig further down into the data. So when we do download a pump, we can then look at the day by day and see, where boluses were given, what the pump was doing in the background, which is these sort of pink waves, and then make decisions about what we alter. And there's very strong evidence base for the different hybrid closed loop systems. And this is the work that we did that fed into the new NICE technology appraisal that's given us reasonably good access to hybrid closed loop in the UK, and something that Partha has worked incredibly hard on, making sure that we've got access to the people who could benefit the most to really improve our long-term outcomes with diabetes. But we had HbA1c reductions in old money of 1.7%, which in new money is about 18 millimoles per mole in individuals who had an elevated HbA1c to start with. And what that represents is probably the single most beneficial intervention for type 1 diabetes that we can do. And this is why we're rolling it out nationally. And when you see people with type 1 diabetes, if you're seeing them on wards or in other clinics, there's a wide range of people who can now access hybrid closed loop. The pink is basically summarising that anyone who was on a pump already can probably be justified going onto a hybrid closed loop. Also, because the cost difference is fairly minimal, because most of them will be using Libre already. But now anybody with a HbA1c more than 58, with disabling hypos, so that doesn't necessarily have to mean unconscious, but that could mean anyone who's struggling with exercise because of hypos, they can access hybrid closed loop. All children and young people, and around pregnancy, so that's really going to improve pregnancy outcomes for women with type 1 diabetes, we hope. The challenge that this introduces is that at the moment, hybrid closed loop and pump therapy has been kept within subspecialty services, and actually what we're going to need to do is to make sure that a much broader cohort of individuals working in diabetes have the skills equipped to manage this technology. And that might be, for instance, within our team at Derby, there are people who do mostly endocrinology rather than diabetes who don't really work with pumps, and we just need to ensure that they have the ability to manage these when people come in acutely to hospital. We need to make sure that we're getting the technology into the hands of people, so we need to think about some of those innovative approaches to delivery of care. So Dr. Brooke, for instance, mentioned patient-initiated follow-up, and that's something that we're very keen, or we are trying to explore for people who are doing really well on this technology and don't need to be seen by us once a year, and can be seen by us maybe once every 3.5 to 4 years when their pump is due for an update. And ultimately what we need is people like you guys in the audience who are enthusiastic about diabetes and want to learn this stuff and want to embed themselves within our services and help support things in the future. But it does go beyond technology, and although my personal bias is towards diabetes technology, there's an awful lot out there. The SGLT2 inhibitor drugs that you'll all have seen people come in on the acute medical take have really changed the game for type 2 diabetes, but not necessarily in terms of glucose management so much as reducing the risk of long-term complications from either CKD or heart failure. And those are sort of the go-to drugs. And increasingly, if I'm getting a referral from the community for someone who's on gliclazide when they could be on an SGLT2 inhibitor, I'll be having those conversations and trying to promote the stopping of those older drugs and commencing something newer. The GLP-1 receptor agonists and the newer dual agonists or triple agonists that are coming out really, again, have changed the game by providing us with a treatment that's a once-weekly injectable that does wonders for people's glucose levels, that helps with weight loss, that has lots of evidence to say that it helps with cardiovascular risk, renal disease, helps with liver side of things as well, so helps with your metabolic associated fatty liver disease. And they are really changing the game and are continuing to develop as we speak, with more and more multiples of agonists in the pipeline from the pharmaceutical companies. We are increasingly recognizing the role of genetics and trying to pick up rarer types of diabetes more than we ever have. So hopefully you're all very familiar with type 1 and type 2. Some of you may be familiar with type 3C, which is because of your chronic pancreatitis or pancreatectomy, but we do have MODY or monogenic diabetes, and we are picking these up. We do have access to genetics done actually by the team at Exeter, and people like Angus Jones are national experts in this, and works with Dr. Brooke. But we've got national guidelines now that say that we can access nationally funded genetic screening for certain individuals, or there may be others who we test and pay for locally because of the way that they've presented. And that means that we can give more targeted treatments. So Some types of monogenic diabetes, for instance, we can treat with glycoside at a really low dose rather than insulin because it's a problem that responds to sulfonylureas. There are other types of genetic diabetes that don't require any treatment at all and just require us to keep an eye on them. And then the final thing that's probably going to come up in the next few years is around immunotherapy and type 1 diabetes prevention. And for this to really work, we do need national screening programs for antibodies or more emphasis on early recognition of autoimmunity in type 1, but that's certainly something that's on the radar as a development, and even things like islet cell transplantation are increasing in their frequency in the UK as well. Beyond that, what's on the horizon? So precision medicine, we've spoken a bit about already, using genetics. Fully closed loop, where people won't have to put in their carbohydrates, is being worked on. The main limitation of fully closed loop is that insulin takes a little bit of time to work, so the responsiveness of any pump to any glucose change is difficult. So having to think of innovative ways. So some companies are, for instance, working on smartwatches that can detect when you're eating based off your wrist movements, so that it knows that you're eating and can safely give you a bolus. Inpatient diabetes technology use will increase because we're going to have more people on hybrid closed loop who come in with other medical conditions, but we don't necessarily know about the role for technology to be initiated in hospitals. So, some hospitals, for instance, might be using in future pumps and sensors to manage your tricky post-stroke patients, on NG feeds with high glucose levels. And we're working on technology beyond type 1 diabetes and other types of diabetes and prevention, and we've got lots more drugs on the way that we're going to need people to know about as well. So that's a little bit of a whistle-stop tour through diabetes and my experience as a diabetologist and what I think is to come. I think it's a very exciting time, and I do wish you all the best in your application. If you choose to become a diabetologist and not endocrinologist, or choose to do a bit of both, I'm quite very happy to take any questions, as I'm sure Dr. Brooke is as well. I'll stop sharing my screen.
Right. Thank you, Dr. Crabtree, for such an amazing talk. This is a very useful introductory session for pre-specialty trainees with limited contact with diabetes technology. So we will now move on to the Q&A session. So please could all participants submit your questions in the chat box, and we will go through them in order. Feel free to also raise your hand and direct your question to the relevant speaker. So at the moment, I don't think I can see any questions in the chat box, but I do have a few questions for the speakers. So my first few questions will be for Dr. Brooke. I'm just wondering, in the interview, will we be tested on specialist knowledge on a certain topic? So for example, like diabetes technology or diabetes in pregnancy, keeping in mind that we are just IMT3 trainees and we might not have approached this topic before in our training.
Yeah, so there is a data bank of questions, and all of the questions are at a level that we would expect you to have acquired through MRCP Part 2. So no, there will not be any questions that are requiring specialist knowledge, because obviously that's the point of training as much as anything. What I would say is there may be some parts of questions that you don't fully know the answer to, and often people panic about that. But remember, this isn't about a yes and no or a right and wrong. It's about how you're approaching a topic, how you're looking and understanding areas of uncertainty and things like that, and actually how you're able to communicate. And honestly, turning up and smiling when you go into the interview room will buy you a lot of credit, because actually, what do people really want? We're all humans, and we're likely to be biased by people that we think that would make a nice colleague in the future. So always be pleasant and nice and engaged, and it's absolutely fine to express uncertainty, but no, you won't be tested on detailed knowledge. I think one of the things that actually is quite difficult, and perhaps given Partha's not here, it's worth just touching on international medical graduates, because they actually make up the highest proportion of our trainees now. So in the last recruitment round, I think 60% of our trainees were international medical graduates. So what often happens is people have had quite extensive diabetes and endocrine training before coming to the UK. And as IMT3s, you're encouraged not to do diabetes and endocrine, but try and get a broad experience outside of that specialty. And of course, that's very difficult to then look at actual knowledge base when someone's done a specialty for a long period of time. And therefore, as much as is possible, we do not judge on your clinical experience of that, because that's what we would hope you to gain. But secondly, we're much more interested in how you're able to communicate, how you're able to structure answers, and what you might be dogmatically enforcing even when you're being gently encouraged to think of a broader answer. It's amazing how many people will persistently go at something, even if they're more or less being told that that's not the right line of inquiry. So that's as much what we want to know. And I'd say that the single thing that trips people up most in the medical interviews is probably around being convincing that you are able to manage a medical take, because actually time is short, and that is something that is very stressful for trainees if they haven't had enough experience of managing a busy medical take, and often then impacts on their ability to gain the specialist parts of their curriculum. So I would strongly encourage you to get experience of that, and until you've got over that initial hurdle, which all IMT3s or junior registrars have, which is that terror of the idea of being the person making the decisions in the hospital. Whereas hopefully you all know as you go through it that actually that terror is unfounded, because there's always people around to ask who can share with you that burden of decision making, and it can be fun. Does that answer your question, Florence?
It has. Thank you so much. Yeah, so I've actually done a few medical on-call shifts as a take registrar, and I think the anxiety gets eased further, like going to my training, because I get more experience and more confidence in dealing with the medical take. That's good.
Yeah, and also you can give the boring old cellulitis to an F1, and you can see the really exciting
delegation to my juniors.
Yeah,
exactly. Sure. And my other question would be, how do you balance between GIM commitments and specialty training requirements? Because I think we have two separate portfolios that we need to achieve for a dual CCT. I'm just wondering, is it going to be really busy for trainees to achieve a proper ARCP for two curriculums?
So I suppose the first thing to do, I suppose, hopefully I addressed some of that in the talk, just because that your concern is obviously a very common concern. And I think the first thing to do is actually to try and separate out GIM specialist training from GIM service commitment, because actually the curriculum has also boosted some of the things that you're expected to do in GIM specialist training, particularly going to 20 varied clinics and things like that. And actually you can get some of that experience by doing other things that might be compatible, like going on a cardiology inpatient referral ward round and things like that. And there are also obviously trainees that are, when they're asked which specialty would they like to attend clinics in, number one in all of that is diabetes, because they recognise that 20% of diabetes inpatients plus will have inpatients will have diabetes. So they need to be skilled in that too. So I think once you look at how can I be trained in general medicine, then you're looking at what is the service commitment to general medicine and how do I balance that with specialist training. And it's really hard, partly because obviously there is a service need and someone has to fulfill that. And you have to be quite clever and quite organised. And I think there's several things that you can do. The first is to be really organised when you're meeting your educational supervisors. So try and drive your own training yourself. Say, this is what I need. This is how I think I can get there. You know, you can talk to previous registrars and find out what the pitfalls are in certain rotations. Or this is when, you know, can we assess this at 2 months? If I'm not able to do this, please, can we look at changing my job plan a bit so that it will allow me to do that? And if it really still is a struggle in terms of being able to get to clinics and things like that, and we do know that there are hospitals where that is the case, then actually the GMC survey is a really powerful tool, and ARCP outcomes are a really powerful tool. And I know that some people have concerns about being completely honest in GMC surveys because they worry about that coming back on them if there's small numbers of people. But it really is a very useful tool as from the SAC and from the training program directors, and it absolutely will not come back on your training. I think the other thing to say is, is what we want you to be at the end of this is really good trainees. And actually, if you are not having adequate training, we would argue that there's a really strong case for actually having an extension to training, and not as a punishment, but as an opportunity to really be able to get that extra training commitment. I think the problem we have, and this is something that we're addressing with the medical director of JRC PTB, is we recognise that some people's visas rely on them getting through training in a timely fashion and things like that. So that's very much on our minds. And it goes back to my original point around trying to hit the ground running as an ST4. So if you are confident as an IMT3 running a medical take, if you're able to attend some clinics, it doesn't matter if it's in specialty or not, but start seeing your own patients and start trying to do that in a timely fashion. And then thinking beyond, right, what do I need to get out, but how am I going to write a good clinic letter so that you actually can manage a clinic, because you have much less experience of going into a clinic than I did when I started my training. I used to do clinics 2 or 3 a week as a house officer. So I had much more experience just of that general clinic scenario than you would have. So those are my sort of top tips to get yourself ready, hit the ground running, make sure you're in charge of your training and that you're having those conversations with your educational supervisor. If you feel no one's listening and this is all around service commitment rather than training, that needs to be fed back, because that's the biggest power that the deaneries have. Remember, they give a lot of money to the trusts, that if that training commitment is not being delivered, then they have that potential to take trainees out of that hospital, and no hospital wants that. So they will do their best to accommodate to make sure that you get your training needs met.
Great, thank you so much for your reply. There's a question from the audience about commitment to specialty. What does the panel want to hear? And as there are lots of things related or unrelated to D&E.
I would like you all to think what you would think that we would want to hear. And I know that's a really ridiculous thing to answer back, but actually, in some ways, a bit like reading CVs or anything else, what we want to know is that you're really thinking about it. What are the challenges? What is Tom finding difficult as a new consultant? Is there anything that you could help with, or anything that he's noticed when he started that able to do a QIIP in, or something like that? Is there something like going to a patient organisation and saying, what are your challenges at the moment? Can I fundraise for you? Can I do this? Something, I guess what I'm trying to say is something that shows that you are going to be a colleague in the future, that when you are my consultant colleague, I'm not going to be the one doing all of the extra bits, and that you're up for it and you're enthusiastic and you are someone that's putting your hand up to do things. And that is, I guess, my biggest tip. In terms of commitment to specialty, if you have done something outside of your job that shows some interest, presenting a case at a local regional thing that has an endocrine flavour to it, or something that just shows that you have an interest, that is really strong. If you can then talk enthusiastically about the specialty and what you've enjoyed or learnt about it from your own reading or something else beyond. Tom, what would you say?
Yeah, I think I would absolutely agree. I think it's also about having an enthusiastic idea about why diabetes and endocrinology, I think, as well, because if you come across an interview like it's your backup choice, that doesn't always, do you know what I mean? I don't think that always bodes particularly well. And I think having a really enthusiastic answer to, well, why diabetes and endocrinology? What do you like about the specialty? And that can really be helpful. Yeah.
Great, thank you. So I'll make sure that I'll get involved in more projects in the department so that I can show commitment to the specialty. And some questions for Dr. Crabtree. So what should we do if someone with type 1 diabetes actually presents to the acute medical take overnight with a non-functioning insulin pump, but he's not in DKA yet? So what would you suggest in this case?
Listen to the person in front of you. They should know exactly what to do in this situation. and should be equipped with the knowledge to replace it themselves. If they're in a position where they're not able to do that because they're unconscious or they've not brought the right kit in with them, then you need to stop the pump, secure it, put it somewhere secure, either with the patient, the next of kin, or lock them around the ward with that being documented, because they do cost a small fortune. And you need to put them on a variable rate insulin infusion until they're seen by us the next day.
Great, thank you.
What you need to do. But most patients should know what to do in that circumstance, I would hope.
That's great. And do we ever consider like starting a patient with type 2 diabetes on a hybrid closed loop technology with their own insulin?
No, not in the UK. Internationally, people have been doing it where healthcare systems are more privately funded. In the UK, there is rarely a reason to do it. I guess the other thing is insulin is needed in type 1 diabetes. Insulin, however, doesn't come without its problems, especially for people with type 2 diabetes. It can worsen any weight gain, it can cause hypoglycemia. So, it is needed for management for some individuals. But ultimately, there's lots of evidence that says it increases your mortality, and actually I'd much rather someone be on an SGLT2 inhibitor and a GLP-1 with a HbA1c that was a bit higher, because they're getting all of those additional protective effects, than have perfect blood glucose on a closed loop.
All right, thank you. And yeah, finally, looking into the future, do you think that a PhD is actually essential to secure a consultant job in the UK as an endocrinologist?
I don't think it is. I think there's a pretty good job market at the moment for diabetes and endocrinology. It might be with training bottlenecks that you need one to get into the specialty, but I hope it does. I hope it doesn't end up that way. But there are plenty of opportunities, and if you're interested or want time out of training or want to develop a subspecialty area of interest, there's no better way of doing it than doing a PhD, or taking time out to maybe even do a clinical fellowship, or in an area that you find interesting. No need to rush to the end, take a long and winding road.
Sure.
Yeah, just to be really clear, absolutely not. And I would strongly advise you to do a PhD if you are really interested in taking an academic post. And I would strongly advise you not to do a PhD if you're just doing it because you think it's going to get you a better consultant job. Because really, there are countless opportunities to do things that will get you a good consultant job that doesn't need to be that. And it's really important that as consultant colleagues, as I said right at the beginning, that you all have really different skill sets. So, if there's already a PhD in the department, who needs two of them? There'll be academic colleagues that are spitting right now. But of course, it's a really part of what is actually a pretty academic specialty, but it's absolutely not essential.
Yeah, think about what the other strings to your bow could be. So, there's plenty of opportunity. RCP chief registrar post, for instance, a really good opportunity to develop hospital leadership skills. And actually, lots of people in diabetes and endocrinology have done those, because we are specialties that are, to generalize us as a specialty, we're very collaborative and into that side of things. Or education is the other thing. Think about, I don't want to do this, but maybe I can set up a teaching program for my local IMTs, medical students, to help support them in learning about diabetes and endocrinology, or doing a PG cert if that's what you're interested in. There's loads of opportunities.
And actually, one of the other things that we haven't really talked about, but is really, really helpful, is the YDF group. So the Young Diabetes and Endocrinology Federation, is it? I don't know. YDF. If you put that into Google, it'll come up anyway. If you haven't looked at their website and or joined it, they have loads of stuff. And actually, they're really active in developing stuff to really help young trainees. And actually at the SAC, that's what we're also really focusing on at the moment, is how to hit the ground running in terms of groups of trainees at your sort of level, thinking about going into diabetes and endocrinology. And specifically, what as international medical graduates you might find would be really helpful. There's lots of work done around international medical graduates for generic hospital stuff. but actually not a lot at the moment of specialty specific stuff. So things like how MDT working might be different, or even things like insulin regimes and you know, what basic sort of differences there are, and we're really trying to look at that as well. So certainly there are loads of opportunities right now, if you are an international medical graduate, to participate in SFE, in, I'm sure, ABCD, but certainly in YDF. They would be, I'm sure, really keen to know about your experience as you go through. So yeah, those are other opportunities that you can have to show a commitment to specialty that would also be really, really helpful.
Great, that's really helpful. Oh, Dr. Brooke, I have another question. So for trainees who actually worked in like DGH hospitals, so they often do not get access to MDT meetings or clinics. I'm just wondering, how would you actually approach this to improve their access to the specialty, to improve their interest to apply for endocrinology?
So it's my hot topic in terms of when you're a trainee, that actually now most MDTs are online. It actually is not impossible to join MDTs. I guess what you need to do is pick the ones that might be useful before you go into a training program, because I think some complex disease MDTs can be a little bit difficult to grasp until you've got a basic grasp of the specialty. So in some ways, I don't think necessarily the MDT should be the focus right at the start. I think that joining an endocrine ward round, going and sitting in a clinic with, dare I say, endocrine specialist nurses or diabetes specialist nurses and look at what they do. I think all of these things are things that, again, show to specialty. Looking on the patient's website, the patient support websites, there is so much really valuable information. I think you'll learn as much about how to present in interviews and things like that by doing that at this stage than you will be by joining an MDT. When you're a trainee, I am strongly encouraging trainees throughout their training program, whatever hospital they're in, to taking the network opportunities that they can. And, you know, even if you can, carrying on following patients that you've seen somewhere so that you know what happens to them, because that, again, is just really helpful learning experience.
Great, thank you for this. So I think there are no further questions in the chat box unless anyone wants to shout out from the audience. I'll just give 1 minute.
Maybe we could do a straw poll of you could put an emoji up. I think you can do that from a reaction at the top, and we could give you 3 options, which is who's already decided to do endocrinology. Either you're already a trainee or you decided you're just in the application process or whatever. Who wasn't sure but is a bit more convinced after hearing Tom at least speak, and who has a floating interest but still remains undecided. Should we have a look? So if you can react and send a reaction to us, if you know already that you want to do endocrinology, or you are already a trainee. So you see, I've already decided.
Yeah, I can see that. Yeah.
A few,
I think I've decided.
Yeah. Excellent. And who is still deciding but is edging more towards endocrinology, having heard tonight? Okay, 1 or 2. We've still got to convince you. Excellent. I think we are obviously a slightly biased sample, but actually I think the road is up for endocrinology at the moment, and there's a really strong group of senior leaders that are really trying to make training better for guys coming through. And who is here as a passing floating interest, but actually has decided it's not for them? Is anyone going to fess up to that? Well, that's encouraging, isn't it? Either that or you're too terrified of us to admit the truth, but we'll take that. That's really good. And I would say that actually, in terms of our recruitment numbers at the moment, I think recruitment's variable. So in terms of, I still think if you're a good trainee, there is absolutely no problem getting a number in endocrinology, and I don't think there's any rush to get a number. And if you don't get it first time, you know, I really don't think that that is necessarily representative of your career being over, or that you're not worthy of it. It sometimes is luck of the draw, a bit like MRCP. But you can use that time really valuably to gain experience and come back stronger the next time. So please don't be put off because of that. But I'd also say that actually we've got really healthy recruitment numbers at the moment. And I think that just is representing the fact that people recognise there's opportunities now in diabetes and endocrine that are really exciting. So it's a really good time to think about applying. I'll stop on that note.
Sure. All right. Thank you to both speakers who have actually shared their pearls of wisdom to everyone today. And I hope you are now inspired to consider a career in diabetes and endocrinology. Just a reminder, this webinar will be uploaded to the Society's YouTube channel and member page. And we will be sending everyone a survey in the next few days, and you'll receive a certificate of attendance once you've completed the survey. So this brings the end of the webinar. Have a wonderful evening, everyone. Goodbye.
Thanks, Florence, for chairing.
Thank you for sharing. Great job.
Thank
Have a
you.
good night, everyone.
Bye, everyone.
Good night. Bye.